Welcome to Chapter 18, Community as Client. Listed on this slide and the next slide are our objectives for this chapter. What is a community? The WHO defines a community as a group of people, often living in a defined geographical area, who may share a common culture, values, and norms, and are arranged in a social structure according to relationships which the community has developed over a period of time. Members of a community gain their personal and social identity by sharing common beliefs, values, and norms which have been developed by the community in the past and may be modified in the future. Typologies are really just an additional way or a different way to define a community. It uses a category rather than a single definition. One typology of community described by Bloom in 1974 is actually still being used today. The categories of communities include communities defined by geopolitical boundaries, by their interactions, such as between schools, social services, and governmental agencies, and by their ability to solve problems. Box 18-2 on page 398 in your textbook lists several types of communities for you. Please take a look at that. Communities of place are where interactions occur in a specific geographic area. The neighborhood and face-to-face communities are two types of this kind of community. Communities of special interest or resource communities cut across geographic areas. Common concerns and interests, which can be long or short-term in nature, bring their members together. For example, a group to support a smoke-free environment. Another type of community is a community of problem ecology. That's created when environmental problems such as water pollution affect a widespread area. For example, problems such as water pollution can bring together people from areas that otherwise wouldn't share any common interests. Nurses also work in partnership with communities defined by geographic and political boundaries such as school districts or townships or counties. Because the type of community varies, nurses planning community interventions have to take into account each community's specific characteristics. Each community is unique, and its defining characteristics will affect the nature of the partnership. In most definitions, community includes three factors: people, place, and function. The people are community members or residents, and the place refers to the geographic and to the time dimensions, and function refers to the aims and activities of the community. Nurses have to regularly examine how the people, place, and function dimensions of the community shape their nursing practice. They can use both a definition and a set of measures for the community in their practice. Remember back in Chapter 1 we talked about an aggregate as a collection of individuals who have a common or who have in common one or more personal or environmental characteristics. Well, the parts of the community are interdependent, and their function is to meet a wide variety of collective needs. This definition of community includes place and function dimensions and recognizes interaction among the systems within a community. Measures of the dimensions for this definition are listed in Table 18-1. When we talk about the community as the patient or the community as the client, nursing focuses on the collective or common good of the population instead of the individual health. The nurse may work with individuals, may work with families or other interacting groups, aggregates, or institutions, or within a population, but the resulting changes are intended to affect the whole community. The community is the client only when the nursing focus is on the collective or the common good of the population instead of on the individual health. Population-centered practice seeks helpful change for the whole community's benefit. An example would be an occupational health nurse's target might be preventing illness and injury and maintaining or promoting health of an entire company's workforce. Because of this focus, the nurse would help an individual disabled worker become independent in his activities of daily living. She would also become involved in promoting vocational rehab services in the community and seek reasonable employment policies for all disabled workers through community government. Direct nursing care can be a part of population-focused community health practice. For example, sometimes direct nursing care is provided to individuals and family members because their health needs are common community-related problems. Changes in their health will affect the health of the communities they live in. In these cases, decisions are made at the individual level because the individual's health is related to the health of the population as a whole. Improved health of the community remains the overall goal of nursing intervention. Interventions to stop spousal abuse or elder abuse are few examples of nursing interventions that are done primarily because of the effects of the abuse on society and therefore the population as a whole. The treatment of a client for tuberculosis reduces the risk to other community members, and this care reduces the risk of an epidemic in the community. The community client also highlights the complexity of the change process. Change for the benefit of the community client must occur at several levels, ranging from individual to society as a whole. For example, health problems caused by lifestyle, such as smoking, overeating, and speeding, cannot be solved simply by asking individuals to choose health-promoting habits. Society must also provide healthy choices. Most individuals can't change their habits alone. They require the support of family members, friends, community healthcare systems, and relevant social policies. Individuals who have lifestyle health problems are often blamed for their illness because of their choices. However, there is evidence to show that the victim actually can't always be blamed and expected to correct the problem without changes also being made in the helping professions and with public policy. For example, some communities have no smoking areas in restaurants to prevent secondhand smoke from harming others, and this is an example of a community-level policy to change behavior. For goals and means of practice in the community, we're going to talk about 4 things: community health, Healthy People 2020, community partnerships, and strategies to improve community health. The common goal of community health involves an ongoing series of health-promoting changes rather than a fixed state. The most effective means of completing healthy changes in the community is through this partnership. Like the concept of community, community health has 3 common characteristics or dimensions: status, structure, and process, and each dimension reflects a unique aspect of community health. Community health in terms of status or outcomes is the most well-known and accepted approach. It involves biological, emotional, and social parts. The biological part of community health is often measured by traditional morbidity and mortality rates, life expectancy indexes, and risk factor profiles. The question of exactly which risk factors are most important is a matter of ongoing disagreement. The emotional part of health status can be measured by consumer satisfaction and mental health indices. Crime rates and functional levels reflect the social part of community health. Other status measures such as worker absenteeism, infant mortality rates reflect effects of all 3 parts. When viewed as the structure of the community, community health is usually defined in terms of services and resources. Measures of community health services and resources include service use patterns, treatment data from various health agencies, and provider-to-client ratios. These data provide information such as the number of available beds at the hospital or the emergency department visits to a particular hospital. Problems that can be found when structure measures are used are serious. For example, problems related to access to care and quality of care are well known through stories reported in local newspapers. Less well known, but of equal concern, is the false belief that simply providing healthcare improves health. These problems require cautious use of health services and resources as measures of community health. Measures of community structure include demographics such as socioeconomic and racial distribution, age, and educational level. Their relationships to health status are thoroughly documented. The view of community health as the process of effective community functioning or problem solving is well established. However, it's especially appropriate to nursing because it directs the study of community health for community action. Community competence, designed by Cottrell, provides a basic understanding of the process dimension of community health. Community competence is a process whereby the parts of a community, the organizations, the groups, and the aggregates, are able to collaborate effectively in identifying the problems and needs of the community, can achieve a working consensus on goals and priorities, can agree on ways and means to implement the agreed on goals, and can collaborate effectively in the required actions. The conditions of community competence are listed and defined in Table 18-2, and that is on page 402 in your textbook. Healthy People 2020 recognizes the need to work collectively in community partnerships to bring about the changes that are necessary to fulfill the vision laid out in Healthy People 2020. It provides the foundation for a national health promotion and disease prevention strategy built on two goals of increasing the quality and years of healthy life and eliminating health disparities. Hopefully, all of these things together are helping you see that the nursing process in the community setting is a little different. The first step in the nursing process in community is building partnerships. Before we do any assessment, we want to build partnerships and establish who are the gatekeepers, who is it that's going to help us get in where we can make a difference. Lay community members have a vested interest in the success of efforts to improve the health of their community. They are recognized as community leaders and possess credibility and skills that health professionals often lack. Successful strategies for improving community health must include those partnerships as the basic means or the key for improvement. Community partnership is a basic focus of a population-centered approach such as MAP, or Mobilizing for Action through Planning and Partnership. Most changes must aim at improving community health through active partnerships between the community residents and health workers from a variety of disciplines. Unfortunately, community residents are often viewed as only sources of information and receivers of the intervention. This form of partnership is called passive participation. It's the opposite of the partnership approach in which all are involved in assessing, planning, and implementing needed community changes. Our goal is really a community member professional partnership approach emphasizing active participation. And in this, power is shared among the lay people and the professional persons through the assessment, planning, implementation, and evaluation process. Partnership means the active participation and involvement of the community or its representatives in helping change. For example, breast cancer is an issue for rural Native American women, and an active community partnership involving those women helps develop and ensure an ongoing program. Our long-term goal is community empowerment. We want to empower the communities to sustain the changes that are being implemented, and that's really only possible with this active partnership. By the way, partnership is a concept that is essential for nurses to know and to use the concepts of community, community as client, and community health. Experienced nurses know that partnership is important because health is not a static reality. It's something that goes back and forth. Partnership in identifying problems and setting goals is especially important because it brings commitment for all involved. It's like getting your patient involved in development of the care plan. They're going to be more apt to go along with your plan if they've been involved and helped to create that plan. Healthy People 2020 and its goals that include increasing community health led to the development of some partnerships for development of community programs. Some of those are listed here for you on your slide. The National Center for Chronic Disease Prevention and Health Promotion website includes links to CDC-supported public health programs that have already been found to be effective. Links to the guides and kits for the programs can also be found on that website. Now we'll talk a little bit about community-focused nursing process. Most nurses are familiar with the nursing process as it applies to individually focused nursing care, but using it to promote community health makes this same nursing process community-focused. The phases that are directly involved in the community as patient begin at the start of the contract or partnership. So remember, the first step is establishing a partnership, then assessing, diagnosing, planning, implementing, and evaluating. Community assessment is one of the three core functions of public health nursing and is the process of critically thinking about the community. It involves getting to know and understand the community as clients. You start your assessment by clearly defining the client in terms of people, place, and function. Before data are collected in the assessment phase, you want to ask yourself, what are the geographic boundaries of the community? What people are members of this community? What characteristics do they have in common? Once you're clear about the boundaries of community as clients, then the assessment phase can move forward.
The primary goal of data collection is to obtain usable information about the community and its health. The systematic collection of data about community health requires gathering or compiling existing data and generating missing data. These data are then interpreted, and community health problems and community abilities are identified. Data gathering is the process of obtaining existing readily available data. They usually describe the demography of the community, like the age, sex, socioeconomic status, and racial distribution. They include vital statistics and like morbidity and mortality data. Data generation is the process of developing data that do not already exist through interaction with community members or groups. This information is more difficult to obtain and is not statistical in nature. It must be generated about a community's knowledge and beliefs, their values and sentiment, their goals and perceived needs, their norms, the problem-solving processes, power, leadership, and influence structures. These data, called qualitative data, are more likely to be collected by interviews and observation. Several methods to generate this data are necessary. Methods that encourage the nurse to consider the community's perception of its health problems and abilities are as important as the method structure to identify knowledge that the nurse considers essential. Informant interviews, focus groups, participant observations, and windshield surveys are four methods of generating direct data. All four methods require sensitivity, openness, curiosity, and the ability to listen, taste, touch, smell, and see life as it lives in the community. Informant interviews and focus groups are directed talks with selected members of the community about community members or groups, and events are basic to effective data generation. Also basic is participant observation, which is the deliberate sharing in the life of the community to the extent that conditions permit. One thing that makes a big difference in when conditions permit is the identification of a key informant and that's very crucial early in the process. Talking to key informants is a critical part of the assessment. They're not always people who have a formal title or position. Often it's an informal role, but county health department nurses, church leaders, they're often key informants, and they also know many community members and can identify other key informants. Windshield surveys are the motorized equivalent of simple observation. They involve generation of data that helps to define the community, the trends, stability, and changes that all serve to define the health of the community. Three methods of generating data are secondary analysis of data collected by someone else, surveys, and community reconnaissance. In secondary analysis, the nurse uses previously gathered data, such as minutes from community meetings. This can be very valuable because it saves time and effort. Surveys can be used because they take data from a sample of persons that is hopefully representative of the entire population.
Community reconnaissance is really going to the internet to see what you can find. It's kind of like a windshield survey on your computer. There's a lot of information on community or city and county websites where you can get the same or at least some of the information that you would gather from a windshield survey, and it will save you a lot of time, money, and effort. A composite database is actually what you get when you take the data that is generated by one nurse and combine it with information that's been already collected by someone. The benefit of this is the ability to see trends over time. So data are analyzed and synthesized, and then you look for trends or themes. In that, you want to identify community health problems or needs for action, but you also want to identify community health strengths or abilities. Problem analysis seeks to clarify the nature of the problem. The nurse identifies the origins and the effects of the problem, the points at which intervention might occur, and the parties that have an interest in the problem and the solution. Often in the analysis, a map or a matrix is developed. This map will show relationships among the factors that contribute either directly or indirectly to the problem. It's very important because if you are looking at what you see as the highest priority problem, it may share factors that also contribute to other problems that affects their outcome as well. There are multiple models or assessment guides. The Community as Partner model is an example of an assessment guide developed to show that nurses can work with the communities as partners. It shows how communities change and grow best by full involvement and self-empowerment. The heart of this model is an assessment wheel that shows that the people actually are the community. Surrounding the people and integral to the community are 8 identified subsystems.
I gotta go
Housing,
upstairs. She wants to be here
education,
too.
fire and
Okay.
safety, politics and
We're
government,
just gonna teach.
health, communication,
I like
economics,
seeing.
and recreation. These subsystems both affect and are affected by the people who make up the community.
Gaining entry or acceptance in the community is one of the biggest challenges in assessment. The nurse is usually an outsider and often represents a healthcare agency that is either not known or not trusted by community members. Community members may therefore react with indifference or even hostility sometimes to the nurse. Once the nurse gains entry at the initial level, role negotiations begin. Role involves the values, behaviors, or goals that
For the
govern the
voiceover, did you
individual's
have
interaction
timing thing?
with others.
As each slide ends, I have to hit the
Keeping appointments,
forward button.
clarifying community members'
And
needs
then
and
you can turn it
and
into a
respecting
video.
an individual's right to
It's not
choose
hard, it's
whether
several
to work
steps.
with the nurse are often helpful approaches.
help
So I've learned.
Maintaining confidentiality is also very important. Nurses must be very careful to protect the identity of
It's a
community
lot
members who
quicker
provide sensitive
than
or
the lecturing
controversial
class.
information.
And then it leaves the whole class for
Small
whatever.
area analysis can create difficulties of a less personal nature.
Which is really
Potential
cool.
problems with small area analysis include the mistakes made when conclusions are based on data gathered from small areas. For example, calculations of mortality rates in a rural county may be skewed when the denominator is the smallest
Is that you
class
can read
value.
this thing.
This issue often raises questions about the validity of identified health problems. It's useful to look at the same problem by comparing similar health problems at the state and national
For right
level.
here, we might
Then
have
the
to go
nurse
to
is more
market.
confident of the validity of the data.
Is that your recording?
You have to do this little rehearse the timing things.
Helps clarify the problem. This is an important, first step.
And when this slide ends, I'll pause and we can go to Martha's thing. Someone who's probably PowerPoint smarter than me could probably show me a quicker way to do this, but it's the only way that I know. To record each of the individual slides, then you have to rehearse the timing, and that's what this is. Where after it plays what I've said, then I hit forward to the next slide.
So it'll advance automatically when they're watching it?
Yeah, I then turned it into a video. And,
Related to
I
lack
don't
of
think my
regular
son does that,
development.
but I don't know, I'll ask him, I'll
Lack
ask
of
him
an
about
outreach.
yeah, ask, cause there might be a quicker way.
Knowledge deficit
After
among
this one's
families about
pause,
infant
I'll show you
nutrition
on another
and
one.
about WIC. And confusion among families about
Let me go
WIC
pull my stuff
program.
out.
Yeah, pull yours up and we'll come in there. That's the only thing is it really ties your computer up. I'm gonna advance.
The planning phase analyzes the community health problems identified in the community nursing diagnoses and establishes priorities among them, establishes goals and objectives, and identifies intervention activities that will accomplish the objectives. Each problem identified as part of the assessment process must be put through a ranking process to determine its importance. The ranking process, in which problems are evaluated and priorities established according to predetermined criteria, is called problem prioritizing. It takes into account information provided by community members, content experts, administrators, and others who can provide resources. Once high priority problems are identified, goals and objectives are developed. Goals are generally broad statements of desired outcomes. Objectives are the precise statements of the desired outcome. Intervention activities are the strategies used to meet the objectives, the ways change will be affected, and the ways the problem cycle will be broken. Usually, alternative intervention activities do exist, and they must be identified and evaluated. The value or the likelihood that the activity will help meet the objective and finally resolve the problem is important to note. It is more valuable in the long term to educate others to assess infant development than to do it for them. It's also valuable to analyze the change process necessary to complete the objective. Probability or the likelihood that the means can be implemented is highest only when the nurse is involved, because the nurse has more control over self-behavior than over the behavior of others. Although the numbers assigned by the nurse to both value and probability are based on subjective judgment, their products are quite useful. When the scores in the two columns are multiplied, the products give the nurse basis for judging which of the potential intervention activities will be most effective in meeting the objective. Implementation, the fifth phase of the nursing process, involves the work and activities aimed at achieving the goals and objectives. Implementing efforts may be made by the person or group who established the goals and objectives, or they may be shared with or even delegated to others. Having a central authority to oversee the efforts to start up and carry out a plan is important, and the nurse's position on this issue can be affected by a variety of factors. Nurses can act as content experts, helping communities select and attain task-oriented goals. Content-focused roles are often considered change agent roles, whereas process roles are called change partner roles. Change agent roles stress gathering and analyzing facts and problem-solving skills, and activist advocate. Implementation mechanisms are the vehicles or the modes by which innovations are transformed from the planners to the community. The nurse alone is never considered an implementation mechanism. Change on behalf of the community client requires multiple implementation mechanisms. Small interacting groups, which are formal or informal, are essential implementation mechanisms. Formal groups include families, legislative bodies, healthcare clients, and service providers. Informal groups might be neighborhoods or social action groups. The common tie among these diverse groups is that they are located between the community and individuals. Because of their intermediate position, they can and do act to both support and prevent change efforts at the community and individual levels. They are potentially powerful precisely because they are mediating structures. Lay advisors are people who are influential in approving or vetoing new ideas and from whom others seek advice and information about new ideas. They often perform a function similar to that of early adopters. They can be identified by their agreement with the community norms, heavy involvement in formal social groups, specific areas of skill and knowledge, and a slightly higher social status than the followers. Mass media are particularly useful in creating change among late adopters or those who are last to embrace the change. Groups dominated by early adopters and lay advisors can also be reached through mass media. Mass media would include the internet, newspapers, television, radio. They are an impersonal and formal type of communication. They're useful in providing information quickly to a large number of people. Health policy can play a critical role in the adoption of healthful population-centered change. The major intent of public policy in the health field is to address collective human needs, and it often limits individual choice in order to serve the public good. For example, drivers have been urged for several years to wear automobile seatbelts. Well, you know that that's actually a law, but the incidence of automobile fatalities wasn't reduced until drivers were required to lower their speed. If public policy that will encourage or even simply allow health-generating choices is to become law, then the nurse has to actively lobby for that. Evaluation begins at the planning phase when you set goals and measurable objectives and goal-attaining activities are identified. After implementing the intervention, then only meeting of the objectives and the effects of the activities have to be assessed. It's different in community. We're not just looking to see if the objectives were met, but the nurse also has to decide whether the cost and money and time were worth the resulting benefit. The layperson's role in evaluation is also important. Professionals have adopted partnerships in assessing and implementing more readily than in evaluating. The question of who has the power to define, judge, and institute change in professional activities is an issue. With evaluation, the entire process is open to renegotiation to achieve community health. In community practice, your own personal safety is of utmost importance. An awareness of the community and common sense are the two best guidelines for judgment. Common sense suggests not leaving anything valuable on the car seat and not leaving your car unlocked. Similar guidelines apply to the use of public transportation. Calling ahead to clients to schedule meetings will help prevent delays or confusion, and it gives the nurse an opportunity to lay the groundwork for the meeting. For nurses who are just beginning their careers in the community or to start a new position, there are 3 clear sources of information that will help answer your questions. That would be other nurses, social workers, or healthcare providers who are familiar with the dynamics of a particular community. Community members, they are the best sources of information about the community, and the nurse's own observations. Knowledge gained during the data collection phase of the process should provide a solid basis for an awareness of the day-to-day community activities. describing the process of a community assessment, and I encourage you to really go through those, thinking about the lecture and make sure that you understand the process.